So I suppose we know that menopausal symptoms vary from woman to woman, and in the perimenopause, and no two women have the same journey. So we know that 80% of women experience at least one or more symptom of menopause, and that symptoms can last about 7 years on average is what's quoted, but I suppose there's a huge variation on that as well. But we know that 1/3 of women will experience ongoing symptoms longer than this, and that 45% of women experience a more moderate or severe transition, with 25% having quite severe symptoms, and on the flip of that, another 25 having no symptoms. So I suppose it's those women who have no symptoms who maybe put things on the back burner and all of a sudden think, oh, here I am, I'm still in my head that I'm in my 20s, and maybe now it's time in my life to be giving some thought to, maybe lifestyle changes as well as hormonal replacement therapy. So, but interestingly, that 50% of women will experience ongoing lifelong genital urinary symptoms of menopause, the GSM symptoms, and they're the women that I would see a lot in my clinic as well. So looking at the statistics, we know that about 600,000 women are affected by perimenopause and menopause in Ireland, and about half of those women are in employment. And I read something from Louise Dignan. I don't know if you've heard of Louise. She was the founder of the Menopause Hub, which was the first private menopause dedicated clinic. And they did a survey very recently, and about 12% of women had given up employment because of symptoms. So that's a huge loss of expertise. I suppose it's looking at workplace menopause policies is the other area that we could take a look at doing a little bit more work. So just looking at this slide, I don't know if you can see it, it's a little bit dull, but it's quite interesting just to look again. We think, maybe I'm in menopause when my periods stop, but it's obviously a very gradual process. If we look at the graph there, the orange line on the bottom is just looking at your melatonin levels, and they're starting to drop from mid to late 30s. Testosterone, very gradual decline. Progesterone falls off a cliff really there in the mid-30s, and that's often the first sign that women have that they're in perimenopause. So maybe because progesterone has quite a relaxing effect on the body, they feel symptoms of insomnia and anxiety that they never had before, and they're being told they have an anxiety disorder, but maybe it's something that can be hormonally managed. So, and then the estrogen is the blue graph there, and that's looks like a child has just been drawing on the wall with the zigzags up and down. So there are fluctuations in the estrogen levels from, well, it varies I suppose with the woman, but from mid-40s onwards for sure, and that's what causes all those vasomotor symptoms and the psychological symptoms as well. So I suppose I'm here today to represent my own profession, and there is a branch within physio of pelvic health physiotherapy. So a lot of people say I didn't even know there was such a thing as a pelvic physiotherapist. So we would have taken, we're qualified physios who've done undergraduate or postgraduate training in obstetrics and gynecology, and our remit is to assess and help women to manage symptoms of bladder or bowel dysfunction, persistent pelvic pain, painful bladder syndrome, pelvic organ prolapse, dyspareunia, painful sex, and pelvic girdle pain in the peripartum period, as well as osteoporosis, alongside other concurrent medical conditions that person may have. And we're also involved in health promotion through all the life stages. But I think the important thing is that the person in front of us, we see them as a whole person. The biopsychosocial approach, that woman is not just that physical symptom she's coming to us with. And I think a lot of you can identify with that slide. We're the sandwich generation. We're maybe caring for a young family, teens and upwards, as well as aging parents and career and financial pressure. So there's a lot coming at women at this stage of their life. So if we can help out with some of those physical symptoms, then that might make their lives obviously a little bit more tolerable. So I'm going to just look at the effect of estrogen on the systems that I suppose would affect us as physiotherapists. I know Dr. Hartley probably touched on the other systems of the body, so I'm not going to talk about vasomotor symptoms or psychological symptoms, but we don't always realise the huge dependency we have on estrogen and how it affects every cell in our body has estrogen receptors. So if we look at the joints, onset of joint pain is very common, joint pain and aches, and also the cartilage, the Shock absorption in the joints tends to be a little bit reduced as well. So, we see an increase in inflammation within the joint capsule. So, onset of sort of hand pain or common joints affected will be the jaw, spine, knees, ankles, shoulders, elbows, you name it. I'm sure every joint, will be affected. Also in bones, bone density we've spoken about. So there's an increase in resorption of bone as well as a decrease in bone formation. So that obviously leads to osteopenia, and then in the latter stages, osteoporosis. So we see an increase in spontaneous fractures, particularly of the vertebra. And 1 in 3 women over the age of 50 have osteoporosis. And 1 in 2 of those women will have a reduction in bone mineral density. And will have a fracture. So also if a woman presents with a fracture from a standing height at a young age, then that's another red flag to be looking at. So if you break your wrist just from falling over with a low force, that shouldn't be happening, or a rib fracture. And those women should be sent for a DEXA scan. And also stress levels, increased cortisol levels, which affects bone absorption. So, lots of influences on the bones as well. And the other body part that we don't always think about being affected are the tendons. So again, changes in the collagen turnover and an increase in the breakdown of the fibers, a stiffness of the tendon tissues, and an increase in recovery time. So taking longer to get over soft tissue injuries. So we see a lot of gluteal tendinopathies that used to be called sciatica or piriformis syndrome. And 1 in 4 women over the age of 50 can have gluteal tendinopathy. And rotator cuff injuries, shoulder pain, plantar fasciitis, pain getting out of bed in the morning, weight bearing on their feet, and posterior tibial tendinitis. And you may have heard of the term 50-year-old shoulder. It's all very depressing, isn't it? But there's hope. So I think the genitourinary symptoms then, very common, but one of the symptoms, I suppose, that women aren't always wanting to be forthcoming about. And I think opening up the conversation is normalising these symptoms. So overactive bladder, recurrent urinary tract infections, atrophic vaginitis, the medical term for dryness, painful sex, low libido, and urinary incontinence affects 1 in 3 women, and pelvic organ prolapse. So the reasons for that are multifactorial, but we are losing striated muscle, and locally in the urethra as well, we lose about 2% per year. And sometimes obstetric events can manifest around the time of the perimenopause. So maybe an undiagnosed obstetric anal injury, so where there would be an injury to the muscle fibers of the perineum, maybe hasn't become apparent until the estrogen levels start to decline a little. And they're the ladies who say, I just feel a lot of urgency with my bowel control, or pelvic floor pain or pelvic floor symptoms. And that's where the estrogen supplementation can help. And also the topical moisturisers, our local estrogens, are, as we heard Dr. Hartley say, are very beneficial as well. And again, bowel incontinence, about 1 in 5 women over the age of 40 can present with bowel incontinence. So it's not always frank incontinence, it may just be some urgency symptoms or issues with sampling and not being sure what the contents of the bowel are, and just building up an anxiety around that. And maybe that changes their life. They're nervous to go out or go out for a day where they don't know where there'll be a bathroom, and then that has knock-on effects on that person's well-being. I won't cover the menstrual symptoms now, but it's important, we would always say to women, to keep a record of their monthly cycle, because it is our 5th vital sign. So fluctuations there can be a sign of maybe hormonal imbalances, but maybe some other issues as well in the body. So these would be the most common conditions that we would see during perimenopause as pelvic health physio. So the pelvic floor disorder, so the stress incontinence, the overactive bladder, pelvic organ prolapse, and then the bone and the tendon issues as well. So if we start with the pelvic floor muscles, so I don't know what knowledge you have of pelvic floor. I'm going to go into it now in a moment. I suppose we don't give it much thought until things go astray, and that's the way it should be. All of our bodily functions should be automatic. But a little bit of knowledge might just help you kind of lay down good lifestyle habits that can prevent you having problems down the line as well. So our pelvic floor has a lot of functions, so it offers support for our pelvic organs, obviously, control of our bladder and our bowel, pelvic and lumbar spine support, sexual function, It's involved in breathing mechanics as well, and we see a lot post-COVID of patients who've had chronic cough, who have developed pelvic floor issues. So the diaphragm and the pelvic floor work as a unit, so if there's a problem in one, there'll be a problem in the other, and often attending to one can help improve the function of the other, and obviously in obvious function during pregnancy and childbirth. So the main bladder symptoms, just to go through those briefly, so stress incontinence, which would be defined as a small to medium urine loss on coughing, sneezing, laughing, jumping, exercise, or any raise in intra-abdominal pressure. So, you know, from early on in life, you'll see if you're at a kid's birthday party, very few mummies wanting to hop up on the bouncy castle, or, you know, at a wedding, women are like, no, I just can't start doing, you know, jumping jacks on the dance floor anymore. So, you know, they're the times that maybe just the straw that breaks the camel's back, and they might be the only symptoms those women would have. But then maybe those symptoms start to creep in on them and become more easily triggered with maybe coughing or sneezing, or as things progress, then maybe with walking or stair climbing, often coming downstairs actually, or downhill walking. So this will be the most common bladder control problem we would see, and that does respond well to pelvic floor rehabilitation. So some good news there. So we'll take a look at the technique in a moment for how to do the exercises. Now, so the other obvious bladder symptom that we would see a lot of would be the overactive bladder symptoms, and you can have both. So frequent toilet trips would define the overactive bladder, going to the toilet maybe more than every 3 hours. It's an urgency, finding it difficult to hold on to get there on time, and then sometimes not making it, so urgent incontinence or nocturia, nighttime toilet trips. So you can have OAB dry or OAB wet. So again, some of that may be anxiety driven, not necessarily always hormonal, or infection needs to be cleared as well. So it's always important that anyone with OAB symptoms has a urine sample done by their GP just to check that there isn't a low-grade infection that's not being detected. So the OAB Management Advice, so very basic things that sometimes when you sit down with somebody, you know, they realise they're knocking back, you know, a pot of tea by 10 in the morning. So often just taking a look at their input and output and at their bladder mechanics. So, you know, making sure they're drinking enough, so 1.5 to 2 litres a day, and the advice will be that includes hot and cold drinks, so not necessarily all water, and reducing or eliminating caffeine intake, especially 2 hours before sleep to reduce fluids. But, you know, the energy drinks, the Cokes, the fizzy drinks, sometimes acidic drinks like tomato juice or orange juice can irritate the bladder as well. And the advice is just to avoid going to the toilet just in case. And you know, it's a common thing, you know, even with our kids, we're saying, have you gone to the loo before you go to school? Make sure you go. Or you've only gone 10 minutes ago, have a think about it, do you really need to go? So it's kind of being sensible about it, but just not getting into that habit all day, every day. So just now and again, it's fine, you know, but obviously not on a regular basis. And just to sit down properly on the toilet, because we don't empty properly if we're hovering over a toilet seat. And avoid stopping and starting the urine flow. It used to be the advice that was given a while back, but now we say no, it confuses the bladder sometimes. If we do that too often, the bladder doesn't know if it's coming or going. So just go, and then pull your muscles up if you're going to pull up your pelvic floor when your bladder is empty. And also then working with the pelvic floor muscles, so building up endurance or hold time. Often pelvic floor muscles can contract, but they can't sustain the contraction, and then they're gone. So often it's building up the endurance holds with the pelvic floor. So bladder training for overactive bladder would involve just keeping a diary for 3 days of everything you drink and what you drink, and the quantity as well as the quantity of the urine output. And then taking a look at your minimum time between loo trips. So say you're going, for argument's sake, every hour. Well then week on week you'd build that incrementally to 15-minute extra time between toilet trips. So very slowly, very gradually, so that, you know, over about 6 weeks you might have stretched that time interval between toilet trips to about 3 hours. There are techniques you can use to calm down bladder urgency. So simple things, that blue graph there showing you the urge curve. So often when you need to go to the loo, it just suddenly strikes, and always when you're in a queue or you're in a situation where you can't get to the loo. So what do you do there? You know, often we panic and take ourselves off to the loo and then don't get there on time. So the really important thing is to calm that urgency down. It's basically your bladder muscle having a bit of a toddler tantrum. So how do you switch that tantrum off? It's a muscle. So there are techniques you can use, like just stay completely still. The more we move, the more that tantrum will go on. So sit still, stand still, curl your toes or stand on your tippy toes. So literally to claw your toes like that, because it's the S1 nerve root, and that's the same nerve root that supplies the bladder. So it sends a neural signal to the bladder to take a chill pill basically and relax and stop giving you urgency. Because if you think about it, there's no more urine in that bladder when that urgency stops than there was when the urge started. It's just the nerves firing off. It's that sensory signal you're getting. Another thing that's helpful to do when urge strikes is to sit on something firm, like a glasses case, because there's an inhibitory reflex to the bladder with perineal pressure. So again, it's giving that neural input to the nervous system to calm down. And relaxed breathing, because often we hold our breath, we panic, so just not to tense the abdominal wall. And I often say to patients, just put your hand just here, you can try it now if you like, just on your upper tummy, just above your belly button, below your rib cage. And if you imagine you're having your urgency now, you tense that area there, just try to make sure that stays soft. And that means you're not building up intra-abdominal pressure, which may be putting more load down onto the bladder. So just making sure that you breathe into your tummy and not breath hold. And only move once the urge is gone, and then to master get into the toilet on time before you increase the duration between toilet trips. So, calm the urgency down, then you have some control over things, and then you make your way to the bathroom. Or you might say, I'm okay, I can wait another 5, 10, 20 minutes, half an hour, whatever. So it's a very gradual approach, and the website listed there, the OAB.ie, is the Irish sponsored website with lots of resources on there as well. So if we think about pelvic floor exercises and technique now, the NICE guidelines in the UK have stated that to be beneficial, they need to be done for 3 months and to do between 8 to 12 contractions 3 times a day. So that's a tall order with busy lives. So, we do have to kind of get used to doing them in different postures, and I try to get patients doing them in standing as soon as possible rather than all lying down, because who's time to lie down 3 times a day in an ideal world, but that doesn't really happen. The technique, I have a video link there that you can check out. The advice is to inhale to prepare, and I might get you all just to try this now, just at least to have something to take home with you today. So I'm going to get you to stand up for this actually. And if your muscles are very weak, don't be disheartened if you don't feel too much in standing. I'd encourage you to try this lying down at home with your knees bent. So the important thing is to have your pelvis in a neutral position. So make sure your pelvis is not tilted forward with the water pouring out the front of a bucket, if you can imagine it like a bucket of water, or tilting back that way. Just make sure that the water in your bucket is horizontal. So try to pop your hands on your hips to measure that. And so just pour the water out the front, out the back, and make sure you have a nice horizontal pelvis. And I want you to make sure your feet hip width apart, and to keep your upper body, imagine your rib cage is a bit like the old bell on the yard, and that you're not ringing your bell out the front or at the back, but just have a nice quiet little dongle on your bell. Does that make sense? So you're well stacked, and that gets your diaphragm over your pelvic floor. And just holding your hands gently on your hips just gives a little bit of pressure to the muscles also. So I want you to scan your body, make sure you're not tensing your buttock muscles or your tummy or your inner thighs. And I want you to breathe in to prepare, and as you exhale, you're going to draw up your back, your middle, and your front pelvic openings. So imagine you've got like a little pelvic elevator that's pulling upwards in your perineum. So you're pulling up this part here. So if you think about, that's your pelvic floor muscles there, and they're coming from your tailbone to your pubic bone, and you're going to draw up this whole group of muscles. So we don't always realize that they're quite a large group of muscles. And on the exhale. So we'll start that one again. So just breathe in to prepare. And as you gently exhale, I want you to draw up just between your pelvic floor, your back passage, vagina, urethra, drawing upwards like there's a little elevator in that area. Now try and hold on to that while you carry on breathing for 2 to 3 breaths. So holding that elevator without tensing, tummy, buttocks, tummy, or upper tummy, I should say, and try and feel the definite release when you've done your 2 to 3 breaths in and out. So feel your pelvic floor drop back to its starting position. It's like an elevator going from ground floor upwards, we'll say, to the 2nd floor, and then back to the ground floor. So try that one more time. So just breathing in to prepare, breathe in, and as you exhale, draw up back, middle, and front passages, like a little set of traffic lights. Hold your elevator there, carry on breathing for 2 to 3 breaths. That might be a bit more shallow than normal breathing. And then when you've done that, drop your pelvic floor without kind of letting out an explosive So let it go from the pelvic floor locally. Okay, and then that's your slow holds. So you'll be aiming to do that about 10 times in a row, and then try 10 fast ones now. So these are more just like a yo-yo, going up and down, up and down. So you don't need to coordinate these with the breathing. They're a bit more easy to do. So just pull up and let go, pull up and let go. Okay, so I'm not going to make you do 10 of those now. But a nice tip to do is every time you go to the loo, think 5, 5, 5. So think about having your legs in three different positions. So one would be to turn your heels out, like your Dorothy in The Wizard of Oz, about to click your heels to go home, that type of posture. And that makes you activate the back half of the pelvic floor a bit more localized. So just try that. Just try a few little flicks up and down of your pelvic floor. You should feel that more in the back traffic light, and then try it with your heels the opposite way, so toes out, heels in, and again just activating there, and try lifting, squeeze and let go. So squeeze and let go. That would be more the front traffic light. And then if you have your feet parallel, that tends to be all three. So it's a really good thing to do, standing pelvic floor exercise 5, 5, 5. Every time you pop something in the microwave or you put the kettle on, standing at a photocopier, you'll never have a dull moment, yeah. But that's an easy way to fit it into your daily routine, you know. And you can palpate your pelvic floor externally. People often say, how do I know I'm doing it properly? So if you just take your middle finger and just pop it just down over your coccyx. So you have to go quite low, so right down on the tip of the tailbone. And when you're standing, skin on skin, try this at home, and you will feel your coccyx flex. It literally is drawn in and out like that when you do your pelvic floor exercises. Now my model, pelvic floor is separated, or I should say the coccyx is separated. So this is where you should feel, because the muscles when they contract are lifting upwards and forwards like that. Sorry, that way. Okay, so your coccyx is being drawn with them. So that's what you should feel. So the Elaine Miller is a Glaswegian physiotherapist who is also a stand-up comedian. So if you follow her on Instagram, she's a bit of a hoot. But she does daily pelvic floor reminders. And her terminology that she uses to help people remember would be 10 strong, 10 fast, 3 times a day until you're dry, and then once a day, every day until you die. So they're like doing your teeth every day. Just make them part of your well woman routine. They are for life, you know. So I suppose just doing those exercises helps the blood flow and the neural firing to the muscles, and will help with those pelvic support problems that we touched on. And it's important, you know, if your technique is not right, it is worthwhile to see a physiotherapist just to coordinate, because it's not always about pelvic floor strengthening. Sometimes we need to get your alignment straightened out or corrected, or advise you on, you know, ways of holding yourself that fire up your muscles better, and also your breathing mechanics. And sometimes we need to release your pelvic floor. Sometimes pelvic floors, a quarter of pelvic floors, are too active and too switched on all the time, because people are afraid of letting them go. They've been told to work your pelvic floor, and then they go overboard. So, you know, for chronic pain patients, or women with control problems, sometimes that's a subliminal thing that they don't realize they're doing. So it's important to release before you strengthen. So if you are having symptoms, you know, we would advise you to maybe see somebody one-to-one to get that advice. So that's it. So just touching then on pelvic organ prolapse. So I'm not going to go into this in huge detail today, but a prolapse would be defined as when the bladder, uterus, vaginal or anal walls start to slip out of place and bulge into the vagina. So women who experience this often describe a heaviness, pressure or dragging ache in their vagina, and sometimes it can be difficult to empty the bowels fully or the bladder with the presence of a pelvic organ prolapse, and the symptoms will worsen generally after prolonged standing, lifting or a busy day. So the advice is to manage heavy lifting. That slide says avoid, but I would suggest manage. There's some research coming out now. There's an Australian physiotherapist, Laurie Forner, who's done her PhD on managing pelvic organ prolapse, and women need to be strong to lift. So, you know, nobody's going to lift your overhead bag in the bin on the plane. You know, you're lifting 10 kilos there. You're lifting rubbish bags, pushing, pulling all heavy things all day long. So, you know, we need to be strong. So the stronger we are in our body, the less load there will be through the pelvic area. So, sometimes it's the wrong advice to say to a person not to lift, because then they get deconditioned. So the advice now is looking at technique and breathing technique with lifting to minimise that, and avoiding constipation, because that can contribute to symptoms, and to use correct toilet positioning, and I have a slide to show you that in a moment. And exhale for any lifting, pushing, pulling, or even getting out of a chair, because as we go down the path of life, you hear yourself moaning and groaning getting out of a chair very often. I think, I never used to do that when I was 10. So, all the things we took for granted suddenly can become a little bit more of an effort on the body. So if you think about when we groan or we hold our breath, standing up from sitting, if you imagine, you see people have to start to use their arms to get out of a chair, that's building up into abdominal pressure, and that can put a load down through the pelvic floor. So if those fascial supports or the muscles are weak, that's further loading, making the organs sort of head southwards, if you like. So by exhaling, it's like loosening the can on the ring on a can of Coke. You're releasing the pressure, so less pressure down through the organs. So exhale, just blow off steam for any effort. So next time you find yourself pushing a heavy trolley or lifting something heavy, just imagine you're blowing up birthday candles, and engage your pelvic floor at the same time if you can. And it's just better mechanics to limit strain through the pelvic floor. And then aiming to drink the 1.5 litres of water, again, to avoid constipation, and managing weight gain. Remember to practice your pelvic floor exercises, and a pessary can help manage pelvic organ prolapse for a lot of women if they're properly fitted. And not just the ring. Some women need a cube pessary or a more space-occupying pessary that helps support the organs in a better way. So that they are underutilised, I think, in Ireland, but that hopefully will be changing. Support underwear like the EVB sport shorts, have you heard of those? They're like sport shorts, and again, they're great for postpartum women or post-surgery, gynae surgery, or for women managing prolapse, walking their dog. Big dog pulling you on the lead, you want that extra support. And using perineal support on the toilet, which I will talk to you in a moment about. And then surgery may be indicated if conservative measures do not help after 3 to 6 months. So I think it's important that women feel, that they get an opinion rather than disappear into the ether if physiotherapy doesn't work for them. We would always urge women to seek a gynecology opinion. So the types of pelvic organ prolapse, so it's hard to see on the graph there, but basically the first slide is showing you bladder prolapse, the second one bowel prolapse, and then prolapse uterus. So the next slide has some links to a YouTube animations that show you in 3D what they look like. So again, it's nice just to get your head around it, because sometimes it can all be a bit hard to imagine what it all looks like on the inside. So there are the links there. So that's the correct toilet positioning. So using a little footstool, I would always encourage 2, maybe a yoga block, 1 under each foot. The image on the right there just shows you the rectum and how the little red sling is the puborectalis muscle, which is like a lasso. So when we're sitting, it's kind of pulling on the tail end of the rectum. But the closer you are to mimicking a squatting position, to have your knees a little bit higher than your hips is key. And that loosens that lasso, so that there's less of a U-bend for the bladder and the bowel contents to go around. So again, for women living with rectocele prolapse, that can be really helpful. And perineal support then can also help as well. Now, so just the last 2 slides. I know we're coming up to the time. It was a huge topic to cover in half an hour today. So I have lots of links for you to look up your own resources if there was anything there that you wanted to find out more about. Just thinking a little about the bone and the tendon health as well. So getting you thinking, that movement is medicine, and it should be prescribable. We know all the benefits of exercise and movement, so obviously it helps bone health, heart health, prevention of diabetes, and some of the cancers. And a paper was published in 2020 that a lot of the breast cancers is a 55% less risk of recurrence by meeting the WHO exercise guidelines of 150 minutes of activity per week. So stress relief, sleep, obviously it helps with joint pain, and there's an anti-inflammatory component to exercise as well. So I did a chronic pain study day last week, and there's lots of evidence coming out that exercise works some way on the immune system and on the nervous system, suppressing pain. So some is better than none, so it depends on where you're starting from. The guidelines, as I said, are 150 minutes a week of moderate exercise over 30 minutes, say over 5 days. Or you might do 50 minutes over 3 days. If you do a 5k walk, that would be your aerobic exercise done. And then also, if you were doing higher intensity exercises, to do 75 minutes over 3 days. So strength training also is recommended 2 days a week of strength training. And the recommendation is to do 8 to 10 muscle groups with 10 to 15 reps, three sets. At 60 to 75% of your 1 repetition max. So the maximum weight you can lift to lift about 75% of that. So forces on the bone, to increase bone density, we need to put force through the bone. And you know, we say surprise your bones. So the more multi-directional movement you can put through your bones, the better. You know, if you go for a walk, try and choose uneven ground or hilly ground so that you're not constantly walking on a flat pavement all the time. And obviously exercise will help increase your metabolic rate as well, and muscle mass. We're losing muscle fibres with each year. So looking at movement as medicine again, so looking aerobic, we've touched on those guidelines. Strength training, we've touched on that. So examples of weight-bearing exercise to help increase bone density would include things like not just walking, so thinking about, you know, turning on the radio in the kitchen and dancing, skipping, hiking, mountain climbing, stair climbing, up and down the stairs 6 times in your house in a row. You know, on a rainy day, you've no excuse. But just, the bones need force to be put through them to increase bone density. Tai Chi, tennis, squats, lunges, deadlifts. Great resources, the Royal Osteoporosis Society website, the UK one, and the Irish Osteoporosis Society. And they have videos and downloadable fact sheets and exercise programs there for managing osteoporosis. So we're aiming to do 50 moderate impacts a day, and that could be skipping, jogging, hopping as well, and include a little bit of flexibility work just to minimize the risk of, you know, injury, staying flexible. So things like Pilates, yoga and stretching, and maybe over the age of 65 introducing some balance work as well. So it's all very well to come up with all that and put that all out to you, but it's nothing to put it into practice. So, you know, I think start baby steps if you're starting from the beginning, and just look at ways of maybe, you know, ramping in a buddy to help you, and look at short-term goals. So know, if I do this exercise, I'm going to sleep better tonight. Maybe my vasomotor symptoms will be better, and my pain will start to improve, rather than thinking, well, I won't have a hip fracture when I'm 80 if I do this tonight. You know, so it's kind of setting short-term goals is better, and you know, I suppose just to show up for yourself and self-care. So, you know, think about you're doing it for yourself, and put it in the diary so that, you know, it's pre-allotted time 2 or 3 times a week that you get out and do your weight training or buy your weights and have them at home. But, you know, you don't need expensive equipment. Your 5 kilo kettlebells, some resistance bands, buy yourself an exercise mat if it's the case that when you lie down, you know, you need somewhere to lie down. The dog jumps on you, the kids jump on you, but, you know, try and have a dedicated space that you can close the door and have a space to exercise, or you know, obviously your gym membership. So, and have a friend and group exercise, you know, or get a dog. Best thing I ever did was get a dog, and I'd say if anyone checked my bone density in my right arm, she's a small dog, a lively dog, but she pulls a lot on the lead. But she gets me out a lot, and to do something you enjoy, you know. So this is an interesting slide that just looks at the ground reaction forces of different activities. It's very tiny, I know, on the slide here, but walking, if you think about it, would be a scale of 1.2 in terms of the forces put through the joints. But hopping, skipping, jumping, I don't have my glasses on either here now, so I can't read that from here, but you're getting up into kind of the 7s when you're doing your drop jumps from a height, you know, so kind of in between the dancing, the skipping, the hopping, you're kind of 3s and 4s. So that's where you want to be aiming for. So I suppose just in summary then, the Japanese call it our second spring. It's a bit cheesy to be saying that too, and it's coming into November. But, you know, I think if we can make the lifestyle changes and you know, movement and good nutrition, good sleep, and stress management, with either local or systemic HRT, it's not just one thing. And you know, for some women they can't take HRT, and most women can. So that's probably the gold standard. But I think, you know, it's never just one thing, and things we got away with in our 20s, we just can't anymore. So, you know, making those lifestyle changes will go towards, you know, hopefully an easier transition and future-proofing our lives ahead, you know. So that's all I have to say. I have a list of resources there as well, with lots of YouTube links and website links. So I presume we can share those. Yeah. So that's it. So you'll never be bored in a queue again. But I think pelvic floor, muscle training, and the aerobic side, with a couple of days of strength training, you know, you'll see benefits within a few weeks. And we would encourage anybody with pelvic floor training to stick with it for 3 months. And there is an app you can get, the Squeezy app, which helps with compliance as well. You know, often the day slips away and you've forgotten. So it's quite a useful trigger to have that on your phone. Everybody's lives are in their phones these days.